Good evening, everyone. Thank you for your introduction. I'm Shin Kadomoto from Kyoto University in Japan. Well, maybe one of the most powerful driving forces for all ophthalmologists is a desire to fully visualize and evaluate the whole eye fundus. This is considered an essential requirement to ensure the realization of high quality medical care, but how can we do it? So today, I would like to talk about the impact of ultra-wide field swept cells OCT and OCT angiography with OCTS1, which is produced by Canon. And these are my relevant disclosures. And since 1996, the progression of OCT system is very rapid. The change from time domain to spectral domain method enables a faster scan and a better high contrast image quality. Moreover, the swept cells method is much faster and deeper than SD method. Advancement of the optical system enables a wider field of view. A wide FOV provides information on the nasal retina, which is not visible in conventional 9mm OCT. Recent technological advancements have enabled the capture of a 12x12 OCTA image. Wide field montage image techniques are now incorporated into most commercially available OCTA devices. Now we can get a large area of microvasculature information. This year, 2019, Canon has released OCT-S1, which has 80 degrees ultra-wide field swept cells OCT. Here is the outline of my lecture. First, I'm going to talk about the feature of OCT-F1. This is comparison among consumable swept cells OCT images. The Canon OCT-S1 captures 23 millimeters at one time. Compared with other two devices, its scan depth is 5.3 millimeters. That is tremendously deep. Here shows CS. Can I light off? Yeah, thank you. Sorry. Here shows central serous chororetinopathy OCT B-scan. Now, OCT-S1 shows the structure of the vitreous and the choroid-scleral interface without changing focus. Swept cells OCT can visualize ultra-wide vitreous and choroidal structures. OCT-S1 visualizes not only retina but also the choroid. But anyway, the innermost vitreous structures are good to see. Here we can see the premacular bursa, also known as Kitsch pocket, and the supramacular bursa and Maltesian area, which is also known as the insertion of the canal of Clcl. And compared with 16 millimeters Clcl, 23 millimeters OCT-S1 visualize the peripheral and more innermost vitreous structures. OCT-S1 can capture from the vitreous to the choroid up to the 5.3 millimeters deep. This is another case of CSCR. Conventional 16 swept cells OCT can also show us the peripheral serous retinal detachment and the thickened choroid. However, OCT-S1 shows more information about this disease. Not only the PVD information, but also S1 tells where the vitreous body is. Deeper and wider scans help visualizing the further ocular structures. The Canon SS-OCT map can create retinal thicknesses map that far exceeds a conventional 30-degree OCT map. Ultra-wide field OCT map can visualize retinal thinning or edema of peripheral retina. OCT-S1 has also three-dimension visualization software. By calculating the volume OCT data, we can see the 3D retinal surface. This is a case of CRVO. It shows huge and tall retinal edema. To figure out what is happening to the retina, it is important to see both the retinal thickness map and the 3D image. OCT-S1 can take our 80 degrees ultra-wide field OCT angiography. Ultra-widefield OCT angiography images can capture up to 80 degrees of the eye at one time without stitching images. The right image is ophthalmology angiogram, which is superimposed with ultra-widefield OCTA. Ultra-widefield OCTA provides microvasculature up to the mid-peripheral retina, which is almost to the same latitude of vortex vein. The choroidal vessels are well visualized in unfast OCT image, better than OCT angiogram choroidal slab. In unfast OCT image, choroidal vessels are well visualized with high contrast, layer by layer. The example is the pachychoroidal spectrum disease, for example, the CSCR, should be evaluated with unfast OCT. The right image is montaged OCT S1 image. As you can see, the montaged unfast OCT can detect the entire vortex vein, which is equivalent to 4 peripheral retina. The montage image was created with stitching 5 unfast images. By superimposing the panoramic unfast OCT with optus, it can capture the diagonal optus area. This is a case of PDL. The panoramic ultra-widefield OCTA shows non-perfusion area elsewhere in mid-peripheral retina and nicely depicts the retinal neovascularization. In ICZA, we can observe the hemodynamics of choroidal vessels, for example, the plaques or hotspots or flow deficits. However, ICZA is not depth encoded. On the other hand, in unfast OCT, we can get a layer-by-layer information. This unfast OCT animation shows the continuity of choroidal vessels from vortex vein. However, the unfast OCT cannot tell the fluorescein leakage or staining. I think ultra-widefield OCT is not omnipotent to any retinal diseases because the conventional 9mm OCT is better transverse and axial resolution than OCT S1. These are diseases, I think, which is suitable with ultra-widefield SS OCT. Ultra-wide field of view, deep scan, and high penetration by swept source method from vitreous body to the choroidal body makes it possible to visualize good in these diseases. And also, the ultra-widefield OCT angiogram has some advantages and drawbacks. Ultra-widefield OCT angiogram is especially useful for evaluating the non-perfusion areas and the retinal neovascularization in retinal vein occlusion and diabetic retinopathies. Also, ultra-widefield unfast OCT can show us the choroidal vessel dilation, which is known as the pachyvessel, which helps in understanding the pathophysiology of pachychoroid spectrum disease. On the other hand, there are some drawbacks. Ultra-widefield OCTA is not suitable for evaluating the choroidal neovascularization, known as CNV, or microaneurysms or macular ischemia, because the S1 lateral resolution of ultra-widefield OCTA is not sufficient to these lesions. Here, I'd like to share with you some various ocular diseases which is obtained by OCT S1. First comes the PVD, the posterior vitreous detachment. The left schema and the right OCT images shows the progression and stage of PVD. PVD starts from the temporal side of the perifovea and then progresses to the nasal side of the perifovea and fovea and finally to the optic disc. The Canon OCT S1 can visualize the vitreous body and the progression of PVD. We could say that PVD totally occurs if there are no sign of vitreous reflectance adjacent to the retinal surfaces. This is a case of BRVO and PVD stage 3. Compared with 16mm Clcl OCT, the OCT S1 visualized the temporal and nasal vitreous adhesions. Ultra-widefield OCT is good to visualize the vitreous. The next case is a microhole. It is sometimes difficult to evaluate the PVD by 9 mm OCT because of insufficient scan depth and the lacking of the information of nasal retina. Ultra-wide field swept source OCT can provide useful information for PVD to understand the microhole stagings. Next case is Clcl. Clcl, which is recently categorized as pachychoroidal spectrum disease. The ultra-wide field OCT can detect the choroid and the scleral interface in Clcl. The huge serous retinal detachment was completely captured. Unfast OCT is depth-encoded imaging. So unfast OCT can visualize choroidal vessels layer by layer, which is not accomplished with ICZA. In this case, unfast OCT shows choroidal vessel dilation in the hollow layer. Now, Clcl is easily diagnosed with ultra-wide field OCT and thickness map and unfast OCT without using ICZA. However, we should know that only fluorescein angiogram can tell us the leakage point of Clcl. The next case is VKH. This is a case of VKH. As you can see, the IL, SLO, and the color thickness map shows the significant, huge, multiple serous retinal detachment elsewhere, not only at the posterior pole, but also at the peripheral retina. Conventional 9 to 16 millimeters OCT is difficult to visualize nasal side of SLD. However, OCT S1 can visualize SLD at the nasal area. So we can also see the thickness colloid. After steroid therapy, OCT and color thickness map shows the significant resolution of choroidal thickness and SLD. OCT S1 is good for monitoring resolution of the serous retinal detachment and the colloidal thickness with corticosteroids or immunomodulatory therapy. Here comes an ocular tumor. This is a case of malignant melanoma, which is accidentally found by Canon OCT S1. The ultra-wide field SSOCT can detect retinal abnormalities outside of the color fundus photography. If the thickness map shows abnormal color at the peripheral retina, we should recheck and rescan the abnormal area because there should be retinal detachment or ocular tumors. This is a case of retinal hemangioma existed at the far peripheral retina. Actually, the OCT S1 could not detect the ocular tumor in front of you, but using the external fixation lamp enables to take far peripheral lesions. The next is RRD. This is a young woman retinal detachment case. 23 millimeters SSOCT system detected the peripheral retinal detachment that was not detected based on the 16 millimeters OCT scan. The ultra-wide field color SLO system of Optos sometimes shows poor contrast due to the red and green shoot color. In this case, actually, it's hard to tell where the retinal detachment area is, but the area of retinal detachment was well visualized by SLO image and the color thickness map. In RRD case, it is important to refer IL, SLO, and the color thickness map. This is a case of nasal inferior retinal detachment, which is not captured by a conventional 45-degree color fundus photography. OCT S1 detects a nasal inferior retinal detachment without stilling the eye. It is important to refer IL, SLO, and color thickness map in RRD cases. So as I mentioned before at the ocular tumor section, the abnormal thickness area at the peripheral retina should be rescanned with OCT because it could be the ocular tumor or retinal detachment. The next case is RVO. The OCT map shows the vast macular edema. However, we cannot evaluate the perfusion status. On the other hand, the OCT angiogram shows the broad non-perfusion area which exceeds 10 disc areas and the tortuous and the dilated vessels. Combining the OCT map and OCT angiogram helps to diagnose this case as ischemic CRVO without using fluorescein angiography. If we perform this case as ST-OCT, the spectral domain OCT in ischemic CRVO, the marked signal attenuation occurs because of the severe retinal ischemia. However, the ultra-widefield swept source OCT can visualize choroid-scleral interface and peripheral macular edema. This case is a chronic CRVO with macular edema. His visual acuity was 2400. OCT S1 shows the tremendous huge macular edema over 3000 micrometers. Mirror artifact occurs in conventional spectralized OCT because of the insufficient depth scan. However, 5.3 millimeters depth scan enables to visualize this huge macular edema without mirroring artifact. This is a case of chronic BRVO. The thickness mark visualizes the yellow macular edema and white asterisk retinal thinning due to the retinal ischemia. The ultra-widefield OCTA shows yellow arrowhead collateral vessels and yellow asterisk non-perfusion areas. So it is important to know the pathophysiology of retinal vein occlusion can be evaluated with OCT map and OCTA without fluorescein angiogram. This is a case of chronic BRVO. Ultra-widefield OCTA is very good to visualize the peripheral non-perfusion areas. However, as I mentioned, the drawbacks of ultra-widefield OCTA, it is not good at visualizing small macular non-perfusions. The thickness map visualizes the retinal edema and thus is not detected by conventional 30-degree OCT maps. So OCT S1 can visualize the microvasculature and the structure changes within the mid-peripheral retina. Ultra-widefield OCT and the thickness map and the OCT angiogram are useful to understand pathophysiology of RVO cases. However, we should combine fluorescein angiogram to evaluate the vascular leakage. The next case is retinitis pigmentosa. The OCT S1 shows the peripheral and the nasal atrophy of RP and ellipsoid zone disruption and the bone speckle lesion that cannot be detected using the 9mm OCT scans. Ultra-widefield OCT is very useful in evaluating RP atrophy progression. The final case of this lecture is pathological myopic cases. This is a myopic CNV. It is tough to take myopic eye because the OCT signal attenuation occurs as axial lengths getting longer. And because of shallow scan depths of ST-OCT, mirroring artifacts is inevitable. But OCT S1 image was captured without mirroring artifact. The curvature of the retina, especially the posterior staphyloma, is well described thanks to the profoundly deep scan 5.3 millimeters. So compared with the plexus elite, we can see how deep the OCT S1 is. The final section is application to anterior segment with OCT S1. From this section, this is the additional one, but OCT S1 is actually specialized in retinal scanning, but it can scan the anterior segment from the corneal sclera and angle without using the anterior segment attachment. We can see the microvasculature of not only the retina but also the conjunctiva. Note that the software misunderstands the surface of the conjunctiva as internal limiting membrane, ILM. So we should be carefully measure the quantitative metrics. This is panoramic anterior segment OCT angiogram of conjunctiva in healthy eyes. It's very amazing that how profound and how vast conjunctival vascular network is, and how difficult it is to detect the conjunctival vessels in color slit lamp photography. The left image is a histology of the monkey eye, and the right image is montage image from the cornea, sclera, and retina. Now, we can obtain the pictures of whole eyeballs using Canon OCT S1. In summary, Canon has released an incredibly wide and deep swept source OCT system, which can change our daily clinical life. Ultra-widefield OCT has a 23 long scan and a 5.3 millimeters deep scan. The ultra-widefield OCT-A can capture 80 degrees field of view. So combining the anterior segment OCT and the external fixation lamp, Canon OCT S1 can visualize the almost whole retina. This project was carried out in collaboration with Canon. Thank you for all today. Thank you for your attention.